Good evening, everyone. Um, my name is Maneesh Bhatia. I'm a consultant orthopedic foot and ankle surgeon at University Hospital, Leicester. On behalf of the Education Committee of BOFAS, a very welcome to you all, and thank you very much for spending time with us. So we are restarting Master Techniques this year, and I'll be hosting this very exciting series. And this is the first episode we have got a couple of masters, one on the left, one on the right, which I'll introduce you to you in a second, although they don't need any introduction. The first episode, which is tonight, is on insertional Achilles tendinopathy, the role of calcaneal osteotomy. And Yves on my right is going to talk about the open technique, whereas Hari on my left is going to talk about the endoscopic technique. Without taking any more time, I would like to introduce Yves, who is the immediate past president of IFAS and is currently the head of foot and ankle services at Grenoble. He's also the past president of the French Association AFCP and a co-founder of the French Diploma of Foot and Ankle Surgery. He's a member of the Ankle Instability Group. He has published very widely and has over 100 publications in peer-reviewed journals, as well as more than 500 oral presentations in scientific committees. So he has done so much work, and I've heard him speak before. He's an excellent speaker, and he has done an amazing job on calcaneal osteotomy. So I am going to welcome Yves to come and share your experience with us. Thank you.
Thank you, Manesh, and thank you, Adri, my two colleagues for this meeting of the BOFAS, and thank you, May, for the organization. I would like to deeply thank the BOFAS and the Education Committee to invite me to this meeting. I am very honored and proud. So, what about the Achilles tendinopathy insertional? It's you have to assess the posterior heel conditions. The Aglund syndrome are multifactorial, and mixing bone disorders are the Aglund deformity, the posterior spurs of the calcaneus, the overlength, and we will speak about later on the overlength of the calcaneus, and the cavus foot also. But also we have to deal with soft tissue disorders like retrocalcaneal bursitis, retroachilles bursitis, insertional Achilles tendinopathy, which is the topic, and the gastroc retraction, and all those are mixed and we can call that Aglund syndrome when we speak about insertional tendinopathy. We have here some example of these conditions. So the pre-op assessments for me are based on two examinations. First, the weight-bearing X-ray, weight-bearing very important, in lateral view to assess the calcaneal shape and sometimes the spurs in addition. The traditional measurements are not reproducible, unfortunately, and all the works performed by Fowler and Philippe, Hennegan and Pavlov, Chauveau and Liat in France have demonstrated to be non-reproducible to assess perfectly this problem. So the calcaneal shape is one of the problem in this discussion. And so there is, at the end of our works, only two reproducible measurements. The first one, I have the privilege to define what is a ratio about the X, which is the overlength of the calcaneus, to Y, which is the length only of the grid tuberosity. And when this ratio is under 2.5, that means there is an overlength of the calcaneus, and it's more oftenly related to pain in the back aspect of the calcaneus. And the second one, older, is the pitch angle of rush. When the pathology is over 20 degrees, you have the pitch angle increased. And so we published these first results of this reproducible measurement in OTSR in 2018. The second one examination, very important for me to deal with the treatment, is a distal end condition, the bursitis and the bone bruise related to the MRI. And the MRI is very important in this condition of the calcaneus and the insertional tendinopathy. The last background I would like to deal with is calcaneoplasty, which is a surgical treatment of the posterior aspect. In open condition, there is immediate good results in the literature, but with the time, recurrence, residual complaints are arising at mid or long-term follow-up, and there is a lot of publication on that. More recently, and probably it could be a discussion also with Harry, the minimal invasive surgery seems to show better results at midterm follow-up compared to open, but it was only midterm. We have not to avoid that the intratendinous injury is a strong negative predictive factor first. And the second one, the shape and the orientation of the calcaneus remains unchanged when you do a calcaneoplasty. So we move to the calcaneal osteotomy reported by Zadek, first described, and then there is a lot of publication since. And the two French are Menou in 1998 and my first publication on that in OTSR in 2004. This Zadek osteotomy is a closing dorsal wedge with an anterior cut more or less perpendicular to the plantar aspect with a width of 8 to 10 millimeter, and that shortened the calcaneus. And the immediate result is we change the ratio, and the ratio moved to under 2.5 to over 2.5. We decrease also the pitch angle because it's a geometrical effect of this osteotomy, and the pitch angle of rush preoperatively is under the pitch angle postoperatively. We decrease also the impingement with the Achilles tendon by moving forward the grid tuberosity. That improve functional and clinical results, including athletes, because it was also a debate with some colleagues. Oh yes, but you cannot treat athletes better with this. Yes, we can. And there is publication on the reported in the very recent literature focused on the interest of the Zadek in athletes population. And so we published our second publication on the Zadek. We published our clinical and radiographic analysis and results about 52 cases. So if I go back to the video, the patient is on the lateral position, except if you have to do some additional procedure, but we will discuss later on that. The incision is behind the cerebral nerve track, and so we go immediately to the bone, no subcutaneous dissection to avoid any cutaneous problem with the wound. So the goal is to find the superior aspect of the calcaneus and the inferior aspect where the aponeurosis is inserted. And even this animation is not really the reality, but this is the effect we obtain with this osteotomy. So we remove this wedge, and at the moment that probably will change with the use of the weight-bearing CT. We have not really an assessment of how much you have to remove, but it could be a part of the discussion later on. So we remove this wedge. We try to maintain the plantar aspect to have a real wedge, but we could also, but there is no formal report on that. We could also sometimes break the plantar aspect to improve and to increase the treatment of the pitch angle. But we have to pay attention with that. So we stress a little bit, and then with the dorsiflexion of the ankle, we locked immediately the osteotomy. You know, you can ease the process by plantar flexion to remove the wedge. And when the wedge is removed, we dorsiflex. Then we fix. I decide to fix with a plate because I prefer to put plate than screw in the area of the insertional insertion or the insertion of the tendon. So I use a plate which locking, so very bulky, so that lead to a earlier weight bearing. We look at locking screw. And then we check the stability of the construct. Then the regimen, there is a non-weight bearing cast for 4 weeks. And then after 4 weeks, there is a partial weight bearing and rehabilitation and return to sport, depending on the sport, between 4 to 6 months. The results published in 2021 in the foot and ankle surgery, about 50 cases with 7 years mean follow-up. The mean BOFAS score and the mean Visa A score dedicated to the Achilles tendon improve significantly between the pre-op and the post-op condition. And the ratio, as well, the pitch angle also moved from 2.07 to 3.0 for the ratio, and decreased the pitch angle as well, with statistical value. But another very interesting topic, and it was my clinical assessment in post-operative, was that the feeling that we decrease the level arm for the Achilles tendon. And this decreasing of the level arm for the Achilles tendon improve de facto the dorsiflexion without any gastroc release, because sometimes there is a reconstruction of the gastroc. And this improvement of the dorsiflexion is correlated also to improvement of the functional core. So you can see here how it works, because when we close it, we relax the Achilles tendon and we improve the dorsiflexion. I use this handmade frame to do my third study, what I published in Foot and Ankle Surgery. And so there were a mean improvement of the dorsiflexion of 7.27 degree, which is highly statistically significant, and highly reproducible from one examiner to the other, because we use the ICC. All the mean value of functional score were also significantly improved, AOFAS, EFAS, and EFAS sports, and also a strong correlation between the functional score and the dorsiflexion. So we make cross significance. And the mean value improvement also with the is-on-Y ratio and the pitch angle, even it was not the goal of this last study. But ZADEC is not the only one procedure we have to use to improve the condition of the insertion of the Achilles tendon. Sometimes we have to deal with additional procedure, like the FHL transfer, and the MRI is very important to decide if you have to use or not this FHL transfer, depending on the distal end condition. And when there is a rupture over 30%, I recommend to use, in addition of the ZADEC, to use an FHL transfer to improve the blood supply and the healing. And very, very quickly, you have seen the insertion. I do it as an open procedure, but it could also perform by a minimal invasive or tenoscopic procedure. And the second one is connected to the osteophytes, depending on the size and the aggressivity of this osteophyte. And sometimes when the spurs are very big, you have to disconnect and reattach the Achilles tendon. And as mentioned here, and personally, I use a speed bridge free stem, but we can use what system you want. Which is interesting, I operate in this case the patient in prone position, and I start in prone position by doing external rotation, and so I can perform my ZADEC, and then I put back the patient in the prone position, and I do the FHL or speed bridge procedure. So with all those tools to deal with an insertional tendinopathy in Haglund syndrome, my first step for my first line to consider is to assess the pitch angle and the calcaneal length of the calcaneus. If this pitch angle and calcaneus length seem regular, I think calcaneoplasty could play an interesting role. But in my practice, most of the time, the pitch angle and or the calcaneus lengths are abnormal. And in that case, I recommend the Zadek osteotomy. And my second step of interest is the size and or the position of the calcification and the condition of the Achilles insertion. And when there is a lot of spurs, very big, it could be not enough to move forward the grid tuberosity, and the spur could remain aggressive for the Achilles tendon. And in that case, I recommend to remove the spurs, and we have to make a resection and a speed grid to have a bulky reattachment. And when there is a rupture of the distal end of the Achilles tendon over 30%, in that case, I recommend to add an FHL augmentation. So Haglund syndrome and the surgery of Haglund syndrome is a surgery à la carte, focus on the Zadek osteotomy with some other additional procedure. Probably we need further clinical studies to validate this algorithm, not to validate the Zadek, but to validate this algorithm. And I wish you a pleasant evening, and I recommend to join the FAS community as you did all the time in the past as a BOFAS organization. Thank you very much for your attention.
That's brilliant, Yves. Thank you so much for your nice presentation. What we are going to do is we are going to take question answers at the end once Hari has also finished his presentation. So please, all the audience, please type in your questions in the question and answer link, and we'll discuss. We have plenty of time for discussion. Our next speaker is Kartik Hariharan, who is a very good friend and an excellent orthopedic surgeon. He works at Royal Gwent Hospital in Newport, and he's been working there since 1994. He has been past president of BOFAS. He has a very strong interest in education, and he was a member of the Wales orthopedic teaching program. In fact, he did my appraisal when I was a locum there many moons ago. He is a clinical teacher at the University of Wales in the College of Medicine. He has also been a specialist advisor for NICE for MTP joint replacements. He has featured in BBC4 production, The Incredible Human Foot. He was awarded the Norton Dunn very prestigious oration in 2015. And he has recently been awarded an honorary fellowship by Indian Orthopedic Association. Amongst his multiple skills, he has a special interest in minimum invasive surgery. And Hari, please share your experience with us, please, today. Thank you.
Thank you very much for those kind words. I'm delighted to speak to all of you on this wonderful summer's evening from Wales. I thank the British Orthopaedic Foot and Ankle Society and the Education Committee, and in particular, Maneesh Bhatia and Callum for bestowing this honor upon me, and I'm delighted to be here with you. I'm not going to go over old ground. We know that the word syndrome means it's not simple. And that it consists of a variety of pathological entities. And with the Haglund syndrome, you've got, as Yves had mentioned, you've got calcaneal spurs, bursitis, tendinopathy, which can be calcific or non-calcific, and is a relatively common cause of posterior heel pain. We know that it causes significant footwear issues, and it is functionally disabling, particularly to the elite athlete population, the long-distance runners. As Yves has also mentioned, that there are significant morphological variations of the oscalcis, in particular the long calcaneus or the candy twirl calcaneus. And also, this condition is associated with sagittal malalignment of the os calcis, particularly in cavus, but can also happen with a valgus hindfoot. This operation is not new, or at least the concept is not new. Isidore Zadek from New York City published this paper in 1939, a long time ago. And interestingly, he did this in women with achilobursitis who wore a high heel. So as far as some surgeons are concerned, things have not really changed at all in all these years. So why an osteotomy? And again, some of this might be repetition, but you often find with pure soft tissue procedures, recurrence is often due to the significant soft tissue violation that occurs when you attempt a soft tissue procedure and often leads to multiple surgical reoperations. The detachment of the tendo-Achilles has been shown to actually worsen tendinopathy by the trauma that you cause in the distal part of the tendon. And of course, if you do have a morphological variation of the shape of the os calcis, then when you do a soft tissue procedure, you haven't done anything to alter the shape and make it more normal. So in this sort of a situation, you have a large Haglund deformity with a posteriorization of the posterior cortex of the os calcis. By the orientation of the intratendinous calcification, you can see how the tendo-Achilles is almost inclined posteriorly, causing it to impinge the bursal tissue that lies between the Haglund deformity and the tendon itself. And traditional procedures would include, as was shown earlier, a detachment to the tendo-Achilles, radical excision of all the prominences as well as the intratendinous calcification, and then reattaching it by whatever method of anchoring the tendon back onto its footprint, possibly slightly more anterior. And when you look at an intraoperative X-ray, it all looks very pleasing and says, wow, I've cured this problem. But if you go back to Yves' formulaic ratio, and assess the X1-Y1 ratio, which ought to be more than 2.5, because if it is less than 2.5, there's a strong negative correlation with, strong correlation with impingement. The aim really ought to be to reduce Y1 so as to get a ratio that climbs up that magical 2.5 figure. And thus, when you go back and look at this X-ray, it is pretty obvious that this person's os calcis is significantly abnormal morphologically, and merely by excising all of this tissue, we haven't addressed the primary morphological anomaly that exists in this patient. So the objectives in such a situation ought to be that we elevate the tuberosity by rotating it anteriorly. This is done by excising a cuneiform dorsal wedge, and by elevating the tuberosity, as was very nicely shown by Yves, that you decrease the innate tension in the tendo-Achilles and the gastrosoleus muscle compartment. The idea is to try and get the apex anterior to the plantar tuberosity, and you can do this by anteriorizing the prominence. You can do this open, as was shown in the first stock, or minimally invasively, which is my preferred method. So why do we do minimally invasive surgery in general, but why in this particular situation? The reasons are obvious. You minimize the soft tissue. You almost certainly have a shorter stay. Most of my patients will leave the afternoon of the operation. There is emerging evidence to suggest that there might be a quicker recovery period. The beauty of minimally invasive surgery is that the use of the burr generates a significant amount of bone paste, which acts as an auto bone graft, which may not be relevant in the os calcis, but could be relevant in, say, the distal tibia. But the other beauty of it is just using the small incision that you make to introduce your burr, you can indulge in multi-axial correction and other auxiliary procedures that may be required. I have tended to use Anthony Pereira's algorithm, where my classic indication is where there is an abnormal morphological feature of the os calcis with moderate tendinopathy or enthesitis and a spur length less than 2 centimeters or 1.5 centimeters, and a posterior heel protrusion of less than 1.5 centimeters. Again, one may have to undertake a calcaneoplasty, which again, I don't do endoscopically, I do minimally invasively under fluoroscopy. I do have contraindications. I don't do this in patients who've got active sepsis anywhere in the foot, or an ulcer, or sometimes even a blister in the area of the prominence. I prefer to wait for this to settle down. I don't do this in patients with severe osteoporosis, as there is a very genuine fear of troughing and over-shortening the dorsal cortex of the oscalces. If there is severe tendinopathy, including partial tears, it may be necessary to combine this procedure with an FHL transfer. So it's only a relative contraindication. One mustn't go into the procedure without having the option of an FHL transfer. Preoperatively, all these patients would have undergone essential targeted physiotherapy for insertional tendinopathy. I do a lateral weight-bearing radiograph, but sometimes may also do an axial calcaneal view or a Saltzman view to assess the calcaneal position relative to the tibia. Unlike Yves, who is very fortunate in getting MRI scans, I prefer to get an ultrasound scan to assess the tendon and the bursa, as because it's a real-time investigation, it shows very beautifully the impingement potential of the calcaneal spur against the tendon, and you often find the bursa being squashed between the Haglund deformity and the tendon, and this can be very nicely demonstrated in the ultrasound scan. You can also pick up calcification of the tendon, which may be relevant because you may not be able to do this in isolation and may have to open up the tendon to debride it. So therefore, the MRI scan only comes into force in my practice when I'm suspecting other pathologies such as stress fractures or fragility fractures in my patients. My setup is very similar. I use a floppy lateral position, but I make sure that I'm able to externally rotate the hip in order that I can get axial views to check my screw position. I use a mini C-arm, which is an essential part of the kit that is required for this procedure. Perhaps the most important is the use of a low-speed, high-torque, well-irrigated 3x20 Shannon burr. The 3 millimeter is the diameter of the burr, and the 20 millimeter is the cutting radius of the distal end, cutting length of the distal end of the burr. There are dedicated periosteal elevators which allow you to create a working pocket in the axis of the osteotomy, which is mentioned before, which is perpendicular to the plantar longitudinal cortical angle. I use a 6.5 millimeter cannulated screw set, as I would wish to keep it as minimally invasively as possible. The position of the portal is determined again on fluoroscopy, where the superior endpoint lies in the middle of the dorsal cortex of the oscalces, whilst the distal endpoint of the osteotomy lies just superior to the plantar cortex in front of the origin of the plantar fascia, and you make the incision somewhere in the middle of this area. Studies done in my unit some time ago and published in the Journal of Foot and Ankle Surgery confirmed that the neurovascular bundle lies well tucked in underneath the quadratus plantae on the medial side. So the medial structures are really not at risk at all, perhaps the only exception being the medial calcaneal nerve, which may come into contact with the Shannon burr, but because it's a low speed, high torque burr, soft tissue will almost immediately stop the burr, lessening the risk of damage. Furthermore, Talusan from the Liu-Shon stable demonstrated on the lateral side this safe zone where the anterior line is at the center of the dorsal cortex, and the posterior line lies just anterior to the origin of the plantar fascia. And if you go in this zone, you're highly unlikely to damage any neurovascular structures. As you will see, the position of the portal for the burr lies very close to the anterior line when you wish to perform a wedge excision, as the docking site is the anterior line, and you can excise bone from posterior to this anterior line. Having made this incision, which is less than a centimeter, you spread it until you reach the os calcis, and then you use your periosteal elevators, where this is the line of the osteotomy, and you create a working pocket dorsally and laterally. You don't obviously go to the medial side, and you certainly don't go to the plantar side, because you want the plantar tissues along with the plantar cortex to act as almost as a tension band. And then you go sequentially, because the cutting length of the burr is only 20 millimeters, you cut the dorsal medial cortex extending onto the dorsal cortex, and then you go to the lateral end and you cut that again. You repeat the process on the plantar medial side and the plantar lateral side, but you keep the plantar cortex intact. It's extremely important that you make sure that the plantar cortex is intact, much more so than the open procedure. As you can see, the burr works in a rotational fashion rather than a saw, which works in an oscillating to and fro movement. You rotate the burr upwards to cut outwards towards you, and then you rotate the burr with the burr pointing downwards to cut in the plantar aspect. And you can see that the burr stops short of the plantar cortex here. When you've done that, you get a cut like this, where about 3 millimeters of bone is removed effectively by the burr, and you have got an intact plantar cortex. Then you use the tuberosity portion of the os calcis, much like you'd hold a coconut, and push it up against the burr as it excursions from plantar to dorsal, so that you start carving out bone. You may have predetermined the amount of wedge that you would like to take out, but my way of doing this is on the table. When I find that the posterior prominence slowly decreases until you can barely feel it. This, I feel, is a much more subjective method, but also correlates with the amount of wedge I take out. So I suspect that this is probably good enough to be able to do. You may have to weaken the plantar cortex until such time you're able to close the osteotomy, which you can then hold with a guide pin. As I said before, I use cannulated screws to hold this in position. You get a secure fixation with one screw, but I put an insurance second screw in most cases. The eventual length of the incision is about 8 millimeters or thereabouts. Although size doesn't matter, it's well worth maintaining some soft tissue integrity when it comes to calcaneal skin. The beauty of the minimally invasive technique is that additional shifts or translations of the os calcis are very easy. So after you've completed your wedge and you think you require either a lateralization in the cavus foot, or you want to increase the pitch angle, you want to decrease the pitch angle, all you have to do is then to burr into the plantar cortex so that you can detach the tuberosity fragment now that you've completed the wedge excision. If you use an incision further up superiorly on Toulouson's line, it's very easy to reach the Haglund deformity, and you can use the burr to also perform a calcaneoplasty. Clearly, you can't do anything to the bursa, but I find that once you've removed the impinging Haglund bone, bursitis automatically seems to subside, and you don't require to do anything further to it. Postoperatively, I rely upon my judgment of the patient's intelligence to either put them in a boot for 4 weeks, non-weight bearing, or a cast. And similar to Yves, I start weight bearing them for a further 2 weeks in a protected fashion. I then x-ray them to ensure that all is well, and then mobilize them out of the cast with the physiotherapist. There are variations to the osteotomy. Again, Anthony Pereira published in Foot and Ankle Clinics. Inclination of the osteotomy, particularly in situations where the spur is facing directly posteriorly, and angulation of the osteotomy in this fashion seems to decrease the posterior prominence more effectively. In my personal results, I have 15 patients which were assessed about 3 years ago, and I found that the results were very pleasing. I had one metalwork removal due to persistent pain, although the screw was well buried. I had a transient sural nerve neuropraxia, and then I had to convert one patient to an FHL transfer after a calcaneoplasty some 2 years after I'd performed the Zadek. And I suspect I pushed the Zadek too far to be able to resolve this without the other two procedures. We have not classified the different kinds of calcaneal morphology, but I think perhaps the most common and clinically important is the one that Yves has done in his work. I also still try to ponder as to what part actually works. Is it the calcaneal osteotomy? Is it the increase in blood flow around the osteotomy site? But I suspect it is a combination of both anatomic deprofiling of the posterior and superior aspects of the oscalces, the decrease in impinging, as well as the decrease in the tension of the tender Achilles. And it's a combination of all of these that create the effect that we've seen clinically. I draw your attention to these two papers. These are well worth reading. The first giving us the radiographic analysis to work out what the anomaly is with the calcaneal shape. And the second paper in 2021 confirms our clinical suspicions that detensioning the tender Achilles, which you probably would have done with the gastrocnemius release, as Matt Solon has shown, will have significant benefits in the overall clinical and functional outcomes in these patients. In conclusion, ladies and gentlemen, this is a safe procedure once you've climbed the learning curve, and I would suggest that you go to cadaver courses, maybe 2 or 3, before you can safely do this. It's not for one who hasn't done open calcaneal osteotomies, as you do need to understand the anatomy in the open setting before you embark on minimally invasive surgery. Complications are minimal, and non-union is not an issue due to the auto bone graft generation. If you ask me which I would prefer, my preference would almost certainly be minimally invasive method. We do need to understand what the biomechanical effects on gait and push-off are. In other words, how much of a wedge can I take before there are significant negative biomechanical effects? And this certainly requires some study. And of course, with the MI technique, I've showed you that you can extend the indications without changing position, which is a huge bonus in the oscalces. Thank you very much.
That was a fantastic presentation, Harry. That's absolutely fantastic. So now we are going to kickstart our discussion after these very educational talks. Now, my first question is to both of you. So XY ratio, has there been any study where the XY ratio has been looked at the other side? So if it's asymptomatic side on the other foot, is the ratio same or dissimilar as compared to the side which has got symptoms?
I have not really measured that, but my first publication to define to point out the ratio was a comparison between a population of normal heel to a painful heel. And that was I find that the cutoff value was 2.5. It's sure that in population with Haglund syndrome, I measure the 2 feet and they are similar. And probably the more painful side is the one they use more as usual. But there are probably very mild symptoms on the opposite side, but sometimes they have symptoms of both, and I plan to operate both sides with maybe 3 or 4 months in between.
That was going to be my next question, because if the ratio is same, then it's quite probable that the patient will develop similar symptoms on the other side, which might be asymptomatic initially, but maybe a few years down the line. So if your patient asks you what are the chances of me developing same problem on the other side, what do you say?
I say they are right.
Yes, absolutely. I think you'll find that majority of the time, if you actually examine them, you don't even have to x-ray them. If you examine both feet, you would often find that there is a small heel bump on the other side too. And I think, I don't know whether dominance may play a role. So in somebody who's a footballer, who's a right dominant kicker, you might find that his symptoms are more on the dominant side. This is speculation, but I suspect that that's what it would be, and it's only a matter of time before the other side would catch up. That would be my impression.
Okay, thank you very much for that. Now, Hari, you did mention that there is a big learning curve with endoscopic technique, and one should not just start doing it. One should go to few cadaver courses, 3 cadaver courses you recommended. I wanted to ask Yves about the open technique. So I have not done this procedure myself, but if I'm so impressed with both of you that I want to see my next patient and I want to try this out. Do you think that's reasonable, or I need any further training?
I think you certainly would benefit immensely. Firstly, from trying it on a cadaver, seeing how comfortable you are with it. I do all of my hindfoot osteotomies and midfoot osteotomies and supramalleolus very often using the minimally invasive technique, and I've gotten used to doing it in the hindfoot. I actually find doing forefoot MI is very much more tricky in my hands. Hindfoot is far easier. There's plenty of working space available. I think the second thing, and I was very fortunate because I happened to go and see Joel and David Redfern, and they instill you with a lot of confidence. But I certainly would not do an MI Zadek as the first time. Almost certainly wouldn't do that. I think at least to understand how the osteotomy works, I think an open technique is still very easy. And I think doing an open technique would be the way to get into the MI arena. And certainly for any emerging surgeons, this would be my philosophy. I think you must. I mean, I did several of these open before I actually went in to do the MI technique.
I agree with you that that was also the problem with the beginning of the minimally invasive surgery, especially for the forefoot.
Yeah.
But it was sold as a very easy technique because but it's a pity, but it's like that because it was through a very small incision, so you don't see what you say, what you do, and it's a pity because I think to start minimally invasive surgery, you need to have such an experience with open procedure, and because all the landmarks we described, and especially for me the insertion of the CFL is the beginning of the posterior zone, and also the plantar medial nerve are the second pitfalls. And when you define that, you can see the same in open procedure.
Yes.
And when you know exactly when they are in open procedure, then you can move to the minimally invasive surgery to exactly know when you do with your burr. It's very difficult sometimes not to go too anteriorly when you go through the dorsal aspect. And so that needs a practice, and this practice has to be performed at the cadaver lab, either for the open or for the minimally invasive. So I recommend the cadaver lab.
Yeah, no, absolutely. So good message out there. Now, one thing which I was interested in, Yves, I think you mentioned that if there is more than 30% of involvement of the Achilles tendon with wear and tear, then you would recommend FHL transfer in adjunct.
Yeah.
So my question is, rather than adjunct, why not just do FHL tendon transfer? Do you need to do FHL tendon transfer as well as calcaneal osteotomy? Or do you think if we can just do FHL tendon transfer, it might solve the problem? Because I've not done this osteotomy before, but I've done FHL tendon transfer and it seems to work. What are your thoughts on that?
For both of you? I think it's the same way of thinking than with the calcaneoplasty. When I was a young surgeon, so many years ago, I start my experience with the calcaneoplasty because my boss told me we have to do this to avoid the impingement. And a part of my patients came back and say, okay, it was good for the beginning, but now I am a recurrence of the pain. And so that one I moved to the Zadek. And the FHL transfer for me is the same. That means you have the shape, there is abnormality on the shape. And if you don't treat this abnormality, whatever you can do on the quality of the blood supply will be a failure. So that means when the problem is it's a so long-term follow-up, that means you need to improve the blood supply by an FHL transfer. But please, the first problem is to change the shape. That means a Zadek osteotomy.
Okay, I would add to that. I think you find that a particular problem in the athletic population. So if you've got somebody who has got a lot of pain and he's a long distance runner, he's got a lot of insertional tendinopathy, and you say, well, look, your tendon is completely wrecked. I'm going to take your tendon out, throw it in the bin, and I'm going to put the FHL tendon in. His first and sometimes the only objective is, I want to get back to running. And that's where the problem arises. So they come back. I mean, I've had 2 patients. I haven't had huge numbers of patients come back because a lot of the time they say, oh, I'm just going to take up cycling. I'm not going to run anymore. For the guys who run, you do find that they come back and say it's starting to hurt again. I can only presume that it's because I haven't addressed the calcaneal length issue. The second thing is I've always tended, it's a leap of faith, I've always tended to not put my FHL tendon in the footprint of the original os calcis. I've almost always anteriorized it because of the problem of some patients coming back with painful symptoms. I've almost always anteriorized putting the FHL tendon by about a centimeter or so, so that it decreases the same, because you've got a long tendon, you've got a long os calcis. You saw in that picture where the tendon is almost heading posteriorly. That surely cannot be biomechanically effective. So I tend to anteriorize the plumbing in of the FHL. Again, as I said, it's a leap of faith, and it's just, I'm just imagining that it'll probably decrease the amount of tension in that new FHL tendon.
Thank you very much. That's very interesting. I think it's something food for thought. Sorry. I'm going to take, there are lots of questions appearing. So I'm going to take questions of audience. Rick Brown has asked, is there a correlation between the size of the wedge you take and the improvement you get? So bigger the wedge, bigger the improvement. Is that right? What's your experience, both of you?
I think, I'm sure Yves has got a much more erudite explanation for it. I know that the wedge I take certainly has got almost a linear correlation with better pain relief. I'm still not sure whether it's biomechanically. I don't know what the overall biomechanical effect of it is. What I also don't know is how big a wedge I can take. I mean, you could take a 3 centimeter wide based wedge, but I don't know what it's going to do to it may defunction the tendon Achilles because you've relaxed it so much. So these parameters, I've tended to use Yves' formula and say, look, as long as the ratio comes above 2.5, I'm happy with that. I don't try and push. The one patient where I tried to push the indication of that, I failed, because no matter how much wedge I would have excised, I don't think I would have ever brought that in. And that's perhaps where Anthony's variation by angling the osteotomy might give us a greater excursion whilst taking a lesser wedge.
I think that there is two ways to reply. I think we have to maintain the apex anteriorly to the insertion of the aponeurosis of the fascia. Even if we do it backward with more oblique, you can also improve the move forward of the grid tuberosity, but there is a risk of pain in the insertion of the fascia. So if you maintain the idea that the apex has to be anterior to the insertion of the fascia, I have not done, unfortunately, calculation, but of the amount. But I think that 8 to 10 millimeter was reasonable in my experience, but it's not scientific. And I think that nowadays in Grenoble, but maybe for sure in England, or you have the weight-bearing CT, the cone beam, you can have access to this, and probably it will be the next step of my study. That means I will check all my calcaneus using the weight-bearing with a reconstruction, a 3D reconstruction, and I can use with some tool like a Dizio or what you want. You can simulate your calcaneal, your osteotomy, and then probably if I put a 2.5 as a critical point, I will calculate to have the small amount of reduction to have a good ratio and not too much and not too less. So, but probably that could be the next step. That at the moment there is few reports. So how to plan the osteotomy for pes planus? You don't know how much you have to plan. I start a study with the Malherbe osteotomy to calculate with a PSI, and I use that in my regular practice. I use a PSI to calculate the amount of wedge I have to remove to transform a varus into a normal valgus. And I think we could move the next one to this, to calculate the amount of wedge you have to remove to change first the ratio and to change immediately the pitch angle, because it's automatically calculated by the software connected to the cone beam. So that will be my next research.
Also, Maneesh, the size of the wedge cures different things. So even if you took a wedge which was not big enough, what immediately does is it gets rid of the impingement type pain. The bursal pain is almost instantly offloaded because the bursa is no longer being impinged, but they still continue to have tendinopathic pain. So the one patient that I tried to do, but eventually had to do a calcaneoplasty, was that I tried to push the indications of it, and I thought I had taken an adequate wedge. The patient said, look, it's better. I don't get that sharp pain when I'm climbing stairs or when I'm walking up a hill. I don't get the sharp pain, but I still get the dull ache at the back of the oscalces. So I suspect there is a mathematical way of assessing that, but I don't know what it is. Right?
Exactly. Yeah. But we could achieve that with the weight bearing and the 3D.
Yes.
A last remark on that too much resection could be dangerous, because you can move from a difficult shoe wearing because you have an impingement to an impossibility to shoe wear because you cannot maintain because you cannot maintain the shoe. So the balance is in between for sure, and maybe you can improve the amount and the precision of our surgery by prior planification.
Thank you. Now, we are on this point, and there are lots of questions, and I'll combine. I'm not going to name anyone, but quite a lot of people are asking that if you do this osteotomy, how important it is to excise the calcification or enthesophytes at the same time. You just leave it there. Will it not cause problem?
Good question. As I said to you, I use Antony's formula. So if there is a huge Haglund spur or a posteriorly angled spur, I will almost go in and excise the spur. Preoperatively, if my ultrasound shows extensive calcification, I would probably open the tendon and debride it. If there are multiple partial tears associated with tendinopathy and calcification, I do an FHL transfer. So if you left calcification in the Achilles tendon, you still will not get rid of the pain of the tendinopathy. That's my opinion. And so I have never, if there was a significantly calcified tendon, I would excise the calcification from the tendon and possibly tubularize it a little bit just to give it a chance to possibly recover. And you know, I may combine that with the Zadok, but I certainly would excise the calcification and debride the tendon.
Thank you.
I will be a little bit different option. I think if the size of the spur is a part of the impingement, that means a huge spur, that I have to remove it. If the spur are in the alignment of the Achilles tendon, probably the Zadek is enough. And then if the condition of the tendon are bad, I do an FHL transfer. So I think we have the same philosophy, even the way of, yeah.
Okay, so next question. There are lots of questions, so I want to try to get to as many as possible. The next question from Mike Carment is, why does the haglund get bigger, and does the size correlate with symptoms?
Okay, I mean, in my hands, size doesn't correlate with symptoms. I've seen patients with huge haglund deformities, which with very little symptoms, and I've seen others with quite a small one and complained. And I think it's, again, going back to Yves' argument that there is a calcaneal shape anomaly or length anomaly. So you could have a small spur causing significant impingement if the XY ratio, which is what Yves has basically shown in his paper, that the ratio determines how much, because it's a big predictor for impingement. So if you've got a very long oscalcis, a small spur could cause the impingement. You can see that when you do the ultrasound scan, and that's why I find real-time ultrasonography really useful, because you can actually pick, and then you inject, you can get your radiologist to inject the bursa and say, is that impingement pain gone? And then you can say, well, this must be bursal impingement that's causing the pain. So I don't believe that's the second part of Mike's question, that size really doesn't matter. I don't know the answer to the first question. I don't know why they grow. I have no idea.
I think in summary, which is important is to change the shape. You change the shape because you reduce the ratio and you reduce the pitch angle, and depends on the size of the removal of the wedge. And because of that, you decrease your lever arm, you improve your dorsiflexion, and so you improve your clinical results. And so you have a better quality of life for the insertion of your tendon. And if not, because on MRI or ultrasound, it's a bad pre-operative condition, you must do an FHL in addition. Thank you.
Donatus has complimented you both about your excellent presentations, and he has asked Hari a question. Well, he's asked two questions. Hari has answered one already. So I'm just going to ask the second one. Is it possible to remove exostosis with MIS technique similar to chilectomy as an adjunct procedure?
Yes, absolutely, you can, which is why I said you stick to Toulousan zone, you go further up until your burr is almost sitting on the dorsal cortex, and you can use the burr then to excise the exostosis. What you can't do, I haven't attempted doing that, is to excise a posterior exostosis. I mean, I don't have the courage to doing that because it's too close to the insertion of the tendon. It's almost on the footprint, and I really wouldn't. I wouldn't do that. Certainly, the haglund, you can quite easily excise it, but like a posteriorly angulated exostosis, I wouldn't risk that with MI. I would just open it.
Thank you. Next question is to Yves from Amit Bhargava from Basildon. He asked, Yves, what percentage of your cases require FHL transfer along with your ZADIC?
For maybe nowadays, it's maybe 10%.
Maybe 10%.
Yeah.
Okay. And I'll just take one more question because we're running out of time. I'm sorry, I will try to address all questions afterwards if we get a chance. But Kailash Devalia has asked, is Achilles insertional tendinopathy and plantar fasciitis have same or different pathomechanics?
Could be.
Yes.
If there is a pre-op contraction of the gastroc, and because the gastroc contraction is related to Achilles tendinopathy, Achilles insertional tendinopathy, and plantar fasciitis. So yes, sometimes if there is a very big contraction of the gastroc, yes. But
I agree.
yeah.
No, I think I agree. But if you looked at it in evolutionary terms, lower mammals had a contiguous structure. So the Achilles tendon was almost continuous with the plantar fascia. And I suspect through the periosteum of the posterior oscalcis, because it's only because the oscalcis evolved growing backwards, pushing that lever arm, that we were able to get bipedal. So it's my belief that they are contiguous structures separated by a chunk of bone, and the biomechanical stresses go through the same. So I agree with Yves that if you had a significant gastrocnemius contracture, you will have the same contiguous pathology in both these areas.
Thank you very much, both of you. I mean, there are so many questions, we can go on and on, but we have to, in tradition with the BOFAS Education Committee, try to finish on time. So once again, heartfelt thanks to both of you for excellent presentations. Thank you very much, all the attendees, and date for your diary. The next master technique will be 29th of September, and more details will follow. The QR code will be displayed, and just take a picture of it for your feedback, and then you will receive your certificate after that. And before I forget, apart from everyone, thanks a lot to the Education Committee and May, in particular from the IT team, who has helped us to run this program smoothly without hiccups. So good night, have a good evening, and see you next time on 29th of September.
Thank you very much.
Thank you.
Bye-bye.
Thank you.
Thank you.